Very good afternoon to everyone. This is Batul, the moderator for today's session from IGCP, and I would like to welcome everyone wholeheartedly at our platform for the better exchange of knowledge that is going to be shared by our renowned stalwart who is present here with us today. Well, he is none other than the very renowned orthopedic surgeon, Dr. Rajat Malot sir, who is MBBS, MS in Orthopedics, and Director at Malot Hospital, Jaipur. With such wonderful insights, we are going to talk about the topic for today, which is management of acute bone and joint emergencies in children. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you. Please proceed.
Okay. Good afternoon, everyone. I am Dr. Rajat Malot. At the outset, I would like to thank IJCP for providing me the opportunity to talk on one of the very common topic, that is pediatric bone and joint emergencies, which every doctor almost encounter on a daily basis. So I'll be speaking on some of the very common injuries which can be managed by any general doctor at the small clinic as well. Also, I'll be talking some very basic, so that upcoming students can also take home some good messages, so that they can, in case of emergency, they can manage this condition in a appropriate way. So basically, if we talk of a pediatric emergencies, there are two type of emergencies. One will be a medical emergency, and another will be a sort of surgical or a orthopedic emergency. Now, medical emergency is more like a high grade fever, diarrhea, or any kind of seizures, and those are basically dealt by a pediatric medicine specialist. Here I'll be talking more of a pediatric bone and joint injuries, as well as all kind of lacerations or any kind of surgical emergencies, which either you can treat by them by yourself, or if it is very severe, at least you can refer them to a right place so that they can be managed comfortably. So the most common which I see emergency, which is like a very easy to treat and very common also, and that is a pulled elbow. Now, pulled elbow is basically a emergency which doesn't have any dire consequences, but the panic with the parents and the child is so much that they will disturb you in the middle of the night if the child get this problem. So it is basically due to the pull of the forearm or a hand by a other child or a parent, and as soon as this is done, the child immediately start crying, and the cry is so severe that everyone gets panic, and they don't understand what has happened to the child. He was very playful for couple of minutes back, but then suddenly he started crying, and the crying is non-stop. And as soon as you touch his elbow or a forearm, the cry will be more. So this is a condition which we see very commonly, and almost once in a week I get a call in the night that my child has suddenly twisted his arm or forearm, and after that he's crying continuously. So this is a very common condition up to age of 5 years of age. And the characteristic feature is that just after the episode, the child will cry and he will not allow anyone to touch his arm or forearm. Now, this is the other name is called as nursemaid elbow, and you can see in this figure that as soon as you pull out the hand or a forearm of the child, the radial head gets dislocated, and this is the main reason of pain. Now, whenever you see such condition, that a child who doesn't have any history of fall, and he started suddenly crying, and he's not allowing to touch the elbow, the first diagnosis is a nursemaid's elbow, and the characteristic sign is that the child will always keep his hand in a pronated position. They will never allow you to do this movement. This is because of the radial head dislocation. Now, how do you treat it? It's very easy to treat. First of all, you need to know that this is a pulled elbow, and as soon as you actually forcefully hyperflex it, immediately you will see the popping sound, which sees that the radial head is again come back to its normal position, and it has reduced completely. So this is a very easy technique. There is a beautiful video of mine on a YouTube where you can easily see by searching Dr. Rajat Malot pulled elbow, and you can see that I have explained a complete technique. However, on a short, I will explain you that once there is a pronation, this is condition is called as pronation, and the child characteristically keep the elbow in pronated position, and as soon as you hyperflex it, the immediately this radial head reduced and the pain immediately goes away. The child might cry because of fear for a few minutes, but the pain is completely gone, and as soon as the child goes back home, the child is completely playful and he doesn't have any pain anymore. So this condition you should remember, and you should be able to treat this condition because it is very easy, and sometimes it is not possible for a parents to reach to a pediatric orthopedic surgeon, but at least you can give a try, and I'm sure that most of the time you will be able to reduce it. So this is a video I was talking about. This is freely available on YouTube, and you can just look at the technique on how to reduce it. Now, coming to another very, very common injury, which is called as ankle sprain. And this is very common in children nowadays because of the active participation in sports and other activities. So as soon as the child is playing and if his ankle gets twisted, there is a characteristic pain and swelling on the outer aspect of the ankle, and this swelling is increases very rapidly, and by the night or after a few hours it can be so much that it can cause severe pain as well as uh, uh, inability to walk, so that you need a immediate consultation. Now, this is actually looks very horrible, but most of the time this is because of the sprain of the ligament, and there is no fracture associated with it. However, if you are in doubt, we can take the X-ray of the foot, but in my experience, most of the time X-ray is normal, and it is just because of the torn ligaments. Now, this condition usually heals itself, except that you need to follow this treatment, which is called as RICE. RICE. R means you need to take the rest to the affected part, means that don't allow the child to walk at least for 48 hours. They should rest. Secondly, always apply ice for 20 minutes for 4 to 8 times in a day, and this basically decreases swelling. Then you can apply a crab bandage or a compression to reduce the swelling. And the last is ice, which is elevation to the injured limb, where you can put 1 or 2 pillows behind the leg so that his part get elevated. And after this, you can give some painkillers, either a diclofenac or a aceclofenac preparation as per the body weight. And this can be easily managed in 3 or 4 days with this treatment. Now, the common mistake I've seen by many persons, and sometimes even practitioners also prescribe, they have a tendency to apply a hot pack after any injury, and this is absolutely wrong. Already the part is very inflamed, and if you apply a hot pack, the swelling will increase too much. So whenever there is an injury, always remember that you need to put a ice pack, not a hot pack. And if the injury is very old or if it is a chronic pain, then only hot pack is given. Otherwise, for acute injuries, always ice pack is given. Now, coming to a very technical and a very emergency condition, which is condition is called as slip capital femoral epiphysis. It is basically a disease of the hip in a children, and the age of the children is commonly 10 to 15 years, and it is because of the slippage of the hip ball over the femur, and it is because of the weak bridge, which is called as growth plate, in a child of age between 10 to 15 years. Usually there is a history of injury, but sometimes the injury could be very, very minor. And the main reason for this is that the growth plate in some children, especially if the child is very obese or they have any kind of hormonal disturbances like hypothyroid or any kind of endocrinological problem, their growth plate is very weak, and even a small injury can cause a separation of a femoral head with the femoral shaft because of the weak growth plate. Now, the characteristic symptoms of this is that the child is very, very painful. He doesn't allow to touch or move his affected lower limb. And if you actually examine this child, you are unable to do any kind of movements at the hip because of the severe pain. Now, as I already told you that this is a condition which occurs in 10 to 15 years of age, and the child is usually very obese or they have a history of hypothyroid, and the injury could be either severe or most of the time the injury is very minor. Now, if we don't treat this condition emergently, this can rapidly progress, and there is sometimes if the delay is for weeks or months, the hip get completely separated, and it can lead to the AVN or avascular necrosis of the hip, and it can damaged permanently. So this is a very important emergency condition. If you are at all suspecting a child who is obese and there is a severe hip pain, we need to see the x-ray of this child on an urgent basis. And the main thing here I want to highlight on is that the x-ray should always be taken in two planes, like AP view and a lateral view. And this disease is characteristically picked in a lateral view in the initial stages. So I have seen that lot of practitioners who suspected this but missed this because they always go for a one view, that is AP view, and in that condition it is not picked up. So whenever you suspect anything in a child hip, always go for a two view, that is a AP view and a lateral view. So in a lateral view, it can be easily picked up, and the main easiest treatment in the initial stage is to screw this hip so that it doesn't get further displaced. And this is a very effective treatment if the disease is picked up early, and it can lead to almost a normal hip, and there is no restriction of activities in future. So, in case if I got this child in the middle of the night, we actually ask the X-ray to ask the radiologist to report the X-ray, and if there is a reporting of slip capital, we actually operate this child even in the midnight, because you never know, this hip can slip in a very fast manner, and we can permanently lose this hip if we don't treat them early. Now, coming to other common fractures, that is a pediatric fractures, which are a sort of emergencies for parents, but they can be treated in a nice way by a pediatric orthopedic surgeon. However, these injuries also need to be at least treated in a basic way on an emergency basis, because these are very painful, and it can be very panicky for parents as well. So the most common injury which we see, most common fracture which we see, is a clavicle fractures. Now these fractures are very very common in children's, and this is because either they have a fall from the bed, or somebody pushes them and other child, and whenever there is a fall, this bone immediately gets fractured. Now this fracture is like, the child will stop using that hand or a upper limb, and they will you can see that there is a swelling over the upper chest region, and the child will not move his limb. When we do this x-ray, we find that this collarbone is fractured. Now this collarbone need not to be treated very aggressively. We just need to counsel the patient that this bone usually heals very nicely without any intervention, without any much treatment. We just give anti-inflammatory medicine and a very special brace which is called as a clavicle brace. Now this brace basically immobilize collarbone up to an extent, and the pain is decreased. And as the child have a very thick periosteum, this bone usually unites in 3 to 4 weeks. The only thing we need to explain to the parents is that this bone will initially unite in a little bad position, but as the time progresses or as the child grows, this bone will take its own shape, and there will not be any future problem. So my take home message for this fracture is that don't treat them with a heavy surgery or heavy kind of plasters. They just need a clavicle brace and anti-inflammatory medicines, and this fractures usually unites in 2 3 to 4 weeks without any further future problems. Coming to the next fracture, which is very very common in children, is called as elbow fractures. And basically there are two type of elbow fractures. One is a lateral condyle fractures, another is a supracondylar fractures. Now these fractures are very notorious for causing neurovascular injuries if they are very severe. So they can have injury to the brachial artery which is running just close to the fracture, and they can also damage a nerve, which is median nerve, radial nerve, which are also very close to this fracture. Now, these fractures, at least they need to be treated by reduction on an emergency basis. Simply because whenever there is a fracture, there is an injury to the muscle, as well as there could be injury to the neurovascular structures. But but if you don't treat them on a emergency basis, then they can lead to a
So you can upload your file and then you can continue.
uh, till what I was. Did you hear? Hello. Could you tell me the last slide, ma'am, before the network
So
went off?
before this was the last. Yes, this one was the last slide.
Okay. So I think I'll speak again from here.
Yes, yes, sir.
Okay, so this is again a very common fracture, that is a elbow fractures, and basically there are two type of fractures. One is a supracondylar fracture, another is a lateral condyle fractures. Now these fractures are also very notorious for causing complications, and they need to be treated on an emergency basis, because if you don't treat them, they can lead to a compartment syndrome, which means that there is a swelling in the forearm and leading to the ischemia of the muscle, which can lead to the gangrene and other complication. So this fracture, at least they need to be reduced on an emergency basis. And if the reduction is unacceptable, then you can next day you can take the patient to the OR and can fix them with a K wires. So these fractures, if you encounter any elbow fractures, first you need to see that if there is any pulsation in the radial artery or not. If it is the radial artery is non-palpable, it is an emergency condition. Either it is a kinking of the vessel or there is actually injury to the brachial artery. So this fracture need not to be ignored. They should not be taken in a light manner. And these are very common injuries, and we've seen lot of complication with this fracture. So if you see any kind of elbow fracture in a children, you need to either treat them on an emergency basis, or you need to refer them to the right place, so that the child could not have any further complications, because the compartment syndrome and other kind of vascular ischemia could be a disaster in such children, and they are permanent disability for child. So these need to be treated in a right way. Now, how we treat them, we actually reduce them under anesthesia and put a K-wire fixation in the elbow. And if you do it in a nicely manner, there could not be, there are very good results, and there is no future residual problems in the child after this fracture. Coming to another very common injuries is a wrist fracture that is called as distal radius fracture in children's, and these are very common injuries as the child are engaged in sports or any kind of activities. Whenever there is a fall on outstretched hand, there is an injury to this bone, which is a distal radius, and these injuries are although unite in a very nice manner, but they present with a very characteristic deformity because of the displacement, and it could be a reason for emergency treatment. And usually these are treated with a close reduction, where we actually give a small anesthesia to the children and reduce them, align them, and put a plaster across the forearm and elbow, and within 2 to 3 weeks this fracture unites very fast. We need not to use heavy implants in children for such fractures, and they have a very good remodeling potential. So even if your reduction is 70-80%, they can remodel in a very nice fashion, and there is no future complication. The only thing you need to remember is that it could lead to a very bad deformity and a pain and swelling if you delay them. So it is better to reduce them on an emergency basis, so that they can be treated in a nice way. This is how we treat it. We usually try a close reduction and plaster, but sometimes if the fracture is very unstable, or if there is a massive swelling, or if the alignment is not acceptable, we actually closely put a K wire also sometimes, but most of the time this can be treated with a plaster. Now, coming to a very serious injury, which is called as femur fractures, and femur is a very strong bone, and usually the child get this fracture only when there is a severe injury, like a road traffic accident, or if there is a fall of heavy object on the thigh, and this is absolute emergency condition because it is very painful. There is lot of blood loss, there is lot of swelling and extreme pain for the child. So these children basically need not to be treated at home. They need to be admitted in the hospital, because there is lot of blood loss inside the thigh because of this fracture, and child can be in a hypovolumic shock. So we need to actually not only treat this fracture, but before that we need to basically see that the child hemodynamics is okay or not, and we need to put a IV line, and in case if we see that the shock is too much, we need to transfuse 1 unit of blood also. So they not to be treated on a with a plaster. They need to be they need to be admitted in the ward, or preferably in ICU for 1 or 2 days, so that the hemodynamic part can be taken care of. And once the child is stabilized, we actually need to fix this bone with a elastic nail, which is very common technique now. And you can see that this is how we fix this bone with a elastic nail, and it is a very minimal invasive surgery, where we actually under CM we reduce the fracture and pass this elastic nail from the skin into the bone, and there is not much of a surgery, not much of incision given. It is basically a close reduction and a tense nail fixation. Coming to another very common injury, that is a toddler's fractures, and this is basically a newborn baby who are started walking, and they trip off, and it can lead to a fracture of the tibia. And the characteristic sign is that the child will not able to put the limb, and he will not walk unless this fracture heals. So the parents usually come to us that he was fine and just fell off, and now he is not walking. And when we get this x-ray done, we see that this is a small fracture in the tibia, which is usually spiral, and these are called as toddler's fracture. These are very common, and sometimes they heal so fast that the child doesn't come to us also. They will just tell that he was not walking for 7 to 10 days, and immediately after this 10 days he started walking. So usually these children get these fractures, and it is a hairline fractures. However, if they come to us for an opinion, if you take the x-ray and you see this fracture line, we need to plaster them with a Biloni cast, and with this cast the fracture heals very fast, and child started walking in couple of days. Now, coming to another small injuries like forehead lacerations and lacerations in and around the leg or arm, forearm. These are very common, and these need to be, because if you don't treat them on an emergency basis, they can bleed. And if and secondly, if you don't suture them in a acute stage, later on it can be, put a bad scar on the forehead. So they need to be treated on an emergency basis, and we usually give a small local anesthesia if the child is cooperative, or if the child is uncooperative we can give a small general anesthesia also. But most of the time I usually do it in a local anesthesia. I just grab the limbs by the parents and we just give a local anesthesia. There is not much of pain except the child is very frightened and fearful. But if you counsel them or if you talk to them in a very nice manner, they will allow you to suture this wound, and there is no need of anesthesia in such children's. Now, open fracture in kids are very, very rare injuries, but they can be very, very, disastrous, and it can be treated. It should be treated on an emergency basis. For example, this child come to us with a fracture of the patella with a large lacerated wound on the anterior aspect of the knee. And these are emergency conditions, because if you don't treat them on an emergency basis, there is a high chance of infection going from the outside environment into the bone. And once there is a bone infection, it is very, very difficult to treat. So the open fractures in children need to be treated on an emergency basis. What we do is first we do a thorough irrigation of the joint, and we take this patient to anesthesia in the OT, and after anesthesia we debride the whole wound, take out all the dirt, and then fix the bone temporarily with a K wire or any other fixator. And once the wound heals, then if we need to put a permanent implant, then only we put. Otherwise, usually most of the time the in children's this can be healed with K wire also. So open fractures in kids or open fracture in adults also is a sort of emergency, because there is a lot of wound contamination from the outside into the joint or a bone, and this need to be treated in a very aggressive manner to prevent any osteomyelitis, which is a bone infection. Now, pediatric bone and joint infections are very, very common in my practice, and they are sort of emergencies, because if we don't treat them in a acute manner, they can lead to a complete bone and joint damage. So these are very, very common injuries, and the most common joints in children's which are affected by infection is hip and knee joint. Those are large joints, and they are favorite sites for the bacteria, because here the drugs or antibiotics could not penetrate easily in the joints. So this is a very favorite site for the bacteria. And the most important thing is that there is a risk of damage to the physis, because the growth plate of the bone is usually in and around the knee and the hip. And if this part is damaged by infection, there could be a limb length discrepancy, there could be angular deformities like knock knee or bow legs, or there could be limb length like one limb is smaller, another limb is uh, longer because of the infection. So this has to be treated on an emergency basis. And if you see this is a septic arthritis of the knee in a child, and there is a large swelling and the child is unable to bear weight. There is a very high grade fever, and you can see the swelling in and around the joint. We usually treat them with a surgery by putting a knife and taking out all the pus, and then we send this pus for a culture and sensitivity, and then we start the antibiotics as per the culture for 6 to 8 weeks. Minded bone and joint infections are very difficult to treat, so prevention is a very, very important thing, and treating them early is another option. Which if you are in suspicion, you can go for MRI or any other investigation to pick this infection acutely and treat them in an aggressive manner. If this child comes to us, we usually offer them a surgery at the initial stage only to prevent progression of this disease, and we do a joint irrigation with the antibiotics and start IV antibiotics after admission, and keep this antibiotic for at least 4 to 6 weeks, so that we can get rid of this infection from the bone and joint. Coming to the last and a very, very rare thing which I also discussed in the initial part is a compartment syndrome. Basically, compartment syndromes are not common, but they are sort of emergency condition. If you don't treat them, it can lead to amputation also. So compartment is basically because of the tight compartment, there is a decreased perfusion to the distal extremity, and it usually occurs after a fracture or after kind of any muscle crushing or any kind of injury to the muscles. and there is a, if you palpate the distal extremity, the perfusion could be decreased, and there is a severe pain in the lower limb, and there is a decreased movement also. We need to release this compartment uh, uh, on an emergency basis, or you can say urgent basis, and as soon as this compartment is released, the perfusion is restored and we can save the limb. So compartment syndrome is a very rare condition, but it is extremely one of the most urgent condition which we encounter in orthopedics conditions, and it has to be taken very seriously. If you feel there is a chance of compartment, don't delay in releasing the compartment by putting a knife in the lower limb, and you need to give a liberal incision so that all compartment gets decompressed, and you can save the limb. If you delay the compartment, there is high chance that there is a necrosis of the muscle, and it can lead to the future complications. So with this, I will end my talk. This is again an example of compartment syndrome in forearm. This is very common after forearm elbow fractures, and which I've already discussed, and they also need to be treated in an emergency basis. So with this, I will end my talk, and this is a broad overview of all the pediatric bone and joint injuries or conditions which we encountered in our practice. And the only message here I want to give is that if you are able to manage this condition in a right way, it is good. But at least you should be able to diagnose them so that you can refer the patient to the right place, so that they can be tackled in a proper manner. Thank you so much. If there are any questions, I'm ready to answer.
Thank you so much, sir. Thank you. I hope I'm audible, sir.
Yes, yes, yes.
Yeah. So moving ahead with the question and answers, we have received few questions from the participants. So
Okay.
the first question is related to pediatric fractures. So,
Yes.
what kind of complications should be monitored for the management of pediatric fractures?
Okay. Uh, First and foremost thing is that pediatric fractures have a very high remodeling potential. So the main aim of treating these fractures is not to align the bone in an anatomical fashion. There is high chances that this fracture will be remodeled in a proper manner. The only thing here we want to emphasize is that the pediatric fractures can also lead to a numerous complication. As I already mentioned, one of the serious complication is a compartment syndrome. So as soon as you get this pediatric fracture, you need to immobilize them by a proper slab, and you need to check the distal pulse and extremity. So this is a very important thing. If there is a fracture of elbow, you must need to palpate the radial artery so that you are sure that the circulation is adequate. You can also check all the nerves, median nerve, radial nerve, and ulnar nerve in a child. If there is a femur fracture or a tibia fracture, you need to palpate the distal dorsalis pedis artery so that you are sure that there is no neurovascular injury. So this is the first thing. Second thing is that you need to actually monitor for other kind of complications like general. For example, if there is a femur fracture, you need to monitor the blood pressure of the child. You need to see the hemodynamic condition, because these children have a very low blood amount, and a little bit of around 200 300 ml of blood loss can rapidly deteriorate the condition of the child. So just aligning the fracture is not important. You need to see the other aspect as well, as because even if the fracture is little malunited, it will remodel most of the time, or it can be tackled later also. But the other life threatening conditions like neurovascular injury or a hemodynamic condition of the child need are far more important to monitor and manage.
Thank you so much, sir. Thank you for answering that question. Moving ahead with the other question that we have. Moving ahead with the other question that we have received, and the question is related to And the question is related to how would you manage a displaced fracture in a child?
Or do we manage a displaced fracture in a child?
Right, sir.
Okay, ma'am. So there are two ways to manage a displaced fracture in a child. If one is to just do a close reduction, which means that we actually give a small anesthesia to the child, and we actually put a traction on the fracture site, and we align the fracture with a manually with our hands. And once the fracture is satisfactorily aligned, we plaster them under anesthesia. The basic aim of the plaster is to it prevents the redisplacement of the fracture. However, certain times these fractures are so unstable that once we align them and as soon as we just leave them, they again get displaced. So in that case, we have few options. One is a K-wire fixation, where we immediately reduce the fracture and put a K-wire, as we do in an elbow fracture. Whenever there is a displaced elbow fracture, we first reduce them, but they are very unstable. So we actually put a K-wire across the elbow, across the fracture, so that they can be temporarily fracture can be hold, and then we put a plaster on that. If the fracture is very stable, like in forearm fracture, sometimes they are very stable, so in that case we just apply the plaster without any K-wire. And third is a condition whenever you feel that the bone is very big and you are unable to reduce them or maintain them with a K-wire, we actually put a plate or an intramedullary implant like nail to reduce or maintain that fracture. So there are two aspects. One is to displace fracture, one is to make them align, and secondly to hold it for few weeks so that it aligns in a nice fashion. So if the fracture is very stable, you can just put a plaster. If the fracture is very unstable, you can either put a K-wire, or if the bone is very big, you can either plate or nail them. And this is how we treat this displaced fracture.
Thank you so much, sir. Thank you for answering that question and the other question for our viewers and for making them understand about the topic in such a better manner and in such an insightful manner. Thank you so much, sir. With this, I would also like to thank all our
Okay, ma'am.
viewers for their ardent participation that they have shown by staying tuned with us throughout the session and putting across such and I would like to thank you, Jessica, for taking out your valuable time and for being here and showcasing the PPT and making our viewers understand about it. We hope to have you again next time at our platform with such more interesting topics to be conducted. Thank you so much, sir.
Thank you. Thank you, ma'am. It's my
With this,
pleasure.
we are
Thank you.
concluding the session here for today. Thank you, sir.